Let's explore interventional radiology and compare it to conventional surgery. The goal is to simplify treatment in a way that minimizes patient discomfort, renders general anesthesia unnecessary, and improves the procedure for the patient and lowers the cost. 2024 and beyond, a large segment of the American population will be aging, and during this decade they will experience a host of medical conditions that require imaging to diagnose and treat using interventional radiology services. An interventional radiology team consists of several key members, each with their own roles and responsibilities. Image-guided surgery, or surgical radiology, is a subspecialty of radiology in which minimally invasive procedures are performed using image guidance. Some of these procedures are done for purely diagnostic purposes, while others are done for treatment purposes. First is multimodality image fusion guided procedures. These procedures use cone beam CT in combination with preoperative imaging. Next, we have live guidance of thrombectomy procedure. The interventional radiologists are using live imaging to guide thrombectomy procedures. The third is radiation-free interventional procedures. The future of interventional radiology may include radiation-free procedures advanced by augmented reality and artificial intelligence solutions. Next, we have cancer treatment techniques. Interventional radiologists are using a variety of techniques to treat cancer. These include ablation, which is burning or freezing a tumor, embolization, cutting off a tumor's blood supply, or targeting it with chemotherapy or radioactivity. To become an interventional radiologist requires a medical degree, then you'll need to complete a 4-year residency program in diagnostic radiology. After finishing residency, you'll have an option to pursue a 2-year fellowship in interventional radiology. Interventional radiology is a specialized field that allows doctors to diagnose and treat various conditions without major surgery. And here's how it works. Number one, diagnosis. Interventional radiologists use imaging tests such as ultrasound, CT, or MRI to look inside the body. These images guide them in identifying issue. Number two would be minimally invasive procedures. Instead of traditional surgery, IR involves using small tools like needles and tubes to deliver and perform procedures and treatments to patients. Next would be cancer treatment. IR plays a crucial role in cancer treatment as well. The interventional radiologist is the leader of an interventional team, which includes a radiology nurse. An interventional radiology nurse plays a crucial role in the radiology department. Here are some of the key responsibilities. Patient preparation. They prepare patients for radiology procedures, which include checking vital signs, reviewing medical history and lab results. They also explain the procedures to the patients and prepare them physically, such as shaving a patient's head or administering sedatives, and they set up equipment that is needed. Another duty is during the procedure, they assist physicians by injecting contrast media into the body or inflating the balloons used to treat gastrointestinal and vascular conditions. They also monitor the patient's vital signs during the procedure and report any changes to the physician or other staff members. They also administer medication. Unless an anesthesiologist is present during the procedure, IR nurses have the primary responsibility for any medications given through the procedure. They are also responsible for post-procedure care. After the procedure, patients are generally transported to a recovery area. The IR nurse oversees patient safety and comfort before, during, and after the procedure. Interventional radiology technologists. The radiologic technology program qualifies a technologist to go into different areas of medical imaging. Some technologists specialize in interventional radiology. So let's talk about the interventional radiology technologist. The ARRT offers a credential in vascular interventional radiography. To earn this credential, you must already hold ARRT credentials. The certification process includes completing a certain type and quantity of clinical procedures and structured educational activities. The ART offers also a cardiac interventional radiography credential. To earn this credential, you must already be certified and registered in radiography. You'll need to meet the requirements in structured education, clinical experience, and examination. The certification process includes performing a minimum of 150 repetitions of cardiac interventional procedures and completing 16 hours of structured education. Some of the duties of the IR Tech is to see to patient safety and comfort. They are responsible for ensuring the patient's safety and comfort during the procedure. They are also responsible for operating imaging equipment. They operate specialized imaging equipment to assist in the diagnosis and treatment of various medical conditions. They also will assist with procedures. They assist physicians during the procedures, which may include injecting dye into a patient's veins to detect anomalies, monitoring vital signs. They monitor patients' vital signs during the procedure to ensure that things are going well, and post-procedure care. They provide post-procedure care for patients. They collaborate with radiologists, nurses, and other healthcare professionals to ensure smooth procedures and patient recovery. Interventional radiology, known as image-guided surgery or surgical radiology, is a subspecialty of radiology in which minimally invasive procedures are performed using image guidance. Some of these procedures are done purely for diagnostic purposes, such as an angiogram, while others are done for treatment purposes, such as an angioplasty. Interventional radiology is often referred to as pinhole surgery or keyhole surgery performed with the aid of X-rays, CT, and ultrasound by specially trained doctors called interventional radiologists, and it is often less invasive option than traditional surgical techniques. 8 out of 10 procedures use skin incisions smaller than 5 millimeters. The procedures are usually done in an outpatient setting. 9 out of 10 procedures use only local anesthesia, sometimes with sedation. Interventional radiology procedures may require sedation to make the patient relax and ease their pain, but general anesthesia is usually not needed. Intravenous sedation is the main anesthetic technique used, with propofol, fentanyl, and midazolam being the most commonly used anesthetic agents. Sedation or analgesia can help patients tolerate diagnostic imaging and image-guided procedures by relieving anxiety, discomfort, or pain. Let's look at the IR suite. Recommendations are that the interventional radiology surgical should be at least 650 square feet with 3 to 4 rooms dedicated for IR patient surgical preparation and recovery. Patient flow in the IR peri-procedural areas should be under the control of the IR team and not dependent on recovery room availability related to other services, unless the area is specifically designed for this purpose and procedures. Policies and processes are also established to define and ensure adequate staffing and space need for safe and appropriate patient care. There should be a process in place by which to monitor and optimize patient care and patient procedure and the room turnover. Workflow in the IR should not be delayed by inadequate resources for patient care and recovery after the procedure. In addition to the room size, ceiling height must also be considered to accommodate a biplane system for imaging. A ceiling height of between 9 foot 6 inches and 9 foot 9 inches is required depending on the vendor providing the imaging equipment. The choice of imaging modality in interventional radiology depends on several factors. One would be the procedure type. Different procedures require different types and levels of imaging. For example, some are done in CT, such as biopsies, and with ultrasound. They also depend on the patient condition. The patient's health status and the specific part being targeted can influence the choice of the imaging modality utilized. Each imaging modality has unique strengths. For instance, CT provides detailed cross-sectional images useful for visualization of bone and soft tissue structures, while MRI offers superior soft tissue contrast. Factors such as radiation exposure from certain modalities must also be taken into account, and the availability of the equipment. The availability and condition of equipment at the healthcare facility can also influence the choice of modality used. There are a number of procedures that are performed in the IR suite. So as far as being large enough to hold the equipment, it also has to have area for the crash cart, the team members that are going to be performing the examination, and all of the supplies required to perform the examinations. In addition to being large enough to house all of the personnel, the crash cart, the patient, and all of the equipment, the IR suite also has to house a number of disposable supplies and have them readily available for use in the procedure. These supplies range from needles. These are used for various purposes, such as gaining vascular access or performing biopsies. And the diameter of the needle is measured in gauges. In other words, how big the diameter of the needle is the gauge. The lower the gauge, the larger the needle. So if we have an 18 gauge needle, it's much larger than a 25 gauge needle. Next, we talk about guide wires. These are used to guide the placement of catheters and other devices within the body. The diameter of the guide wires is measured in inches. What we're looking at here is we have to have a guide wire specifically long enough and a specific type of guide wire to go to the area that we are trying to put the catheter in. Catheters and sheaths. These are tubes that are inserted into the body to follow or to allow for the passage of instruments or to drain fluids. The diameter of the catheter and sheaths are measured in French units. We always start with the smallest size French unit because the bore or the diameter of the catheter gets larger as the French units go up. So you want to start with the smallest catheter so you're not traumatizing the entryway with too large a catheter and then bleeding out around a smaller catheter being inserted after the large catheter. There are a number of devices that we use, and a lot of these are things such as stents, balloons, coils, and other specialized equipment used in IR procedures. In addition to the devices, we also have ancillary packs. These are miscellaneous items that are used in IR procedures and are usually packaged up based upon the procedure being done. A suite of rooms to specifically accommodate the sophisticated vascular studies and the equipment needed to perform angiography and interventional procedures. The procedure room should be large enough to accommodate all of the equipment as well as the radiology staff, ancillary staff. Special procedures sometimes even requires general anesthesia that necessitates extra equipment in the room, and also they need to have a crash cart. These procedures are also more hazardous to the patient, and each room must be equipped to deal with an emergency that may occur. Although interventional radiology procedures are often less expensive than traditional surgery, they are not inexpensive. The initial cost, for instance, in stocking disposable supplies in the IR suite would run between a minimum of $100,000 to over $300,000. In addition, there are operating costs for a busy practice, and the supplies are going to be one of the biggest costs in the practice. Things such as guide wires, catheters, balloons, stents, laser fibers, pharmaceuticals, and disposables are all utilized, and some of them have expiration dates and must be discarded if they are not utilized. Interventional radiology produces good clinical outcomes while beating surgery on cost effectiveness in numerous procedures. However, there is a lot of cost in different particular service lines, including the high cost of disposable supplies is because the use of them is time-driven because they have expiration dates. So what kind of things can be done in the IR? We work with internal bleeding, treat cancer, treat aortic aneurysms, work with blocked bile ducts, fibroids, work with blocked kidneys, and speaking of kidneys, we also do dialysis. We work with varicose veins, leg arteries, bone and spine, blood clots, blocked arteries, and blood vessel malformations. So there are many conditions, and here are some of the procedures that we use. Here we can look at some of the procedures that are performed in IR. They range from angioplasty and angiography to embolization, cryotherapy, MR-guided biopsies, radiofrequency ablations, and much more. There will be a detailed presentation of the procedures performed in a subsequent presentation about interventional imaging. But today we're just going to take a brief overlook at some of the procedures. Interventional radiology encompasses a wide range of examinations and procedures, and here are some of the major categories. First, we'll talk about vascular procedures. These include stroke management, carotid artery stenting, balloon angioplasty, and stenting of peripheral vascular disease, and endovenous laser ablation for varicose vein treatment. Next, we'll talk about oncology procedures, and these involve chemoembolization and radiotherapy for cancer treatment, and we direct the delivery of the cancer medicine directly to the tumor site. Another major category is pain management procedures. These include therapeutic injections and other therapeutic management of pain procedures. We also have organ-specific procedures. These include uterine artery embolization for fibroids, biliary drainage for liver disease, nephrostomy tubes for kidney disease, gastrostomy tubes or feeding tubes for the stomach. Another area is structural procedures. These include vertebroplasty and kyphoplasty for spinal fractures. And then we do diagnostic procedures. These include angiography, imaging of the blood vessels, cholangiography, imaging of the bile ducts within the liver, and biopsy, taking a tissue of sample from the area of interest for pathological examination. Other procedures might include dialysis fistula management, chemotherapy ports, PICC lines, biopsies, abscess drainages, and heart flow analysis. Interventional radiology procedures are generally considered safe and less invasive than traditional surgery. However, like any medical procedure, they do carry some risk. We have the risk of radiation exposure. While the risks associated with radiation exposure are minimum, we need to be aware of the exposure to the patient in monitoring how much radiation the patient receives. We also have procedure-related risks. These can include infection, bleeding, damage to the blood vessels, or reactions to the contrast media used in some procedures. And there also can be systemic factors. IR is associated with numerous systemic factors that carry an increased risk of medical error and may result in preventable patient harm. The interventional radiologist needs not only physical skills and stamina, they also need to have the proficiency in radiology to be able to use the imaging techniques such as X-rays, CT scans, MRs, and sonography. They must also be able to navigate instruments like catheters and needles through blood vessels and organs to treat a variety of diseases. Another attribute the radiologist needs is good clinical skills. They need to have a comprehensive knowledge of the least invasive treatments available, coupled with the diagnostic and clinical experience to perform them. Communication skills are also one of the essentials for an interventional radiologist. Good communication skills are essential for explaining procedures to patients, discussing cases with other healthcare professionals, and documenting the procedures. The interventional radiologist needs to be detail-oriented. Being detail-oriented is important for accurately interpreting images and performing precise procedures. Physically, the interventional radiologist needs to have good hand-eye coordination and manual dexterity. These are necessary for performing the delicate procedures. Combined with that is having problem-solving skills so that they can make quick decisions as required, and physical stamina because the role can be physically demanding, as interventional radiologists may need to stand for long periods during the procedures. Let's take a look at some of the skills required for a radiologic technologist working in interventional radiology. They need to demonstrate expertise in using IR equipment and devices and have the ability to adapt to emerging imaging and procedure methods that are changing at all times. They must also be able to troubleshoot issues with tools, devices, and equipment. Prior to doing any procedure, they should have hands-on experience with the procedure and various procedures overall, understand the theory behind these procedures, and demonstrate the ability to apply this knowledge in a practical setting. So they must have hands-on training. The radiologic technologist is also responsible for patient safety, especially radiation safety, by selecting the correct techniques and making everyone aware of the amount of radiation the patient is receiving and minimizing the amount of radiation that is utilized. Communication skills are essential for explaining procedures to patients, discussing cases with other healthcare professionals, and documenting the procedures. Because the procedures are varied and complex and require many types of different disposable supplies and techniques to be able to do the procedure, the technologist must have excellent organizational skills. These organizational skills are required for time management and also managing the multiple patients and procedures that are done each day. Working in an IR lab is a unique experience, different from surgery and different from ER. So the radiologic technologist needs excellent communication skills to communicate with the other healthcare professionals, and also the ability to communicate with the patient. They also need good interpersonal skills. Empathy and compassion are crucial as they often work with patients who may be in discomfort or anxious about the procedure. And like the radiologist and other people working in the lab, they need to have good physical stamina, wearing radiation protective gear and standing for many hours and doing multiple procedures each day requires good physical stamina. Let's take a moment to review some of the disposable supplies that are used in an interventional suite. The first would be guide wires, and these are used to guide catheters and other body instruments. The catheters are flexible hollow tubes used to deliver drugs, contrast agents, or other therapeutic agents to specific areas of the body. We also have needles, and these are used for various purposes, such as gaining access to blood vessels or other body cavities. We utilize stents, and these are tiny mesh tubes that are used to prop open arteries or other vessels. We prop open vessels with stents, but we also use coils, and these are used to create a plug inside a vessel, blocking off the blood vessel, causing a clot formation and cessation of blood flow. We also work with embolization beads. These are used to cut off the blood supply to a targeted area. Sheaths are used, and these are used to introduce catheters or other devices into the body. They're basically a gateway to run the catheter through. IR involves a wide range of procedures, and here are some of the most common ones. Obviously, the first one would be angiography. This is an X-ray of the arteries and veins to detect blockage or narrowing of the vessels. Next, we have angioplasty. The doctor inserts a small balloon-tipped catheter into a blood vessel and inflates the balloon to open up an area of blockage inside the vessel. Or we do embolization. The doctor introduces a substance through a catheter into a blood vessel to stop blood flow through that vessel. This is done to control bleeding. If a patient can't take food by mouth, we often have to use gastrostomy tubes. The doctor places a feeding tube into the stomach to be able to provide nutrition for the patient. Here we see examples of the feeding tubes, and we see a gastrostomy tube in the stomach. Let's talk about angioplasty and stenting. What we're really looking at here is atherosclerosis or plaque in the arteries. So what we're going to do is we're going to introduce a catheter that has a balloon on that catheter. We're then going to blow up that balloon to allow us to insert a stent. The stent is a small wire mesh that's placed inside the vessel at the site of the blockage. The stent is then expanded to open up the blockage and allow blood flow. Another common procedure is to put in an inferior vena cava filter. What this does is this filter catches blood clots that may go into the lungs and cause a pulmonary embolism. The doctor places a small filter in the inferior vena cava, which is a large vein in the abdomen. This filter catches the blood clots that may go to the lungs. Here's a list of other things that can be done in the suite. Treatment of vascular problems, such as angiogram or angioplasty, biopsies, drainage of fluid collections, abscess drainage, kidney or bile ducts or gallbladder drainage, embolization or blockage of arteries to stop bleeding or treat tumors, etc. Remember, if you have a tumor, if you cut off the blood supply to the tumor dies. Treatment of infertility, insertion of feeding tubes, and treatment of liver tumors for chemotherapy. There are a number of reasons that we utilize interventional radiology procedures as opposed to major surgeries. They are faster with better recuperation for the patient. There's usually no hospital admission required if they're done as an outpatient. You can use local anesthesia instead of general anesthesia, and they're generally safe and effective. The Interventional Radiology Suite is just one of the areas in which interventional radiology is practiced. We also use different modalities such as ultrasound, CT, or MRI to target the intervention and show the results of the intervention. Remember, interventional radiology is a subspecialty which provides minimally invasive diagnosis and/or treatment using imaging. Vascular studies and cardiac studies require a suite of rooms to include a room to be able to do the procedure and rooms for patient recovery and patient waiting. Fluoroscopic suites used in interventional radiology should be large enough to accommodate all of the equipment as well as the radiologic and ancillary staff. Special procedures sometimes require a general anesthetic, and this necessitates extra equipment and staff that need to be accommodated as well. These procedures are also more hazardous to the patient, and each room must be equipped to deal with emergencies that may occur, including having a crash cart. One of the responsibilities of the radiologic technologist working in IR is to educate the fellow healthcare workers about radiation safety and about how much they are actually exposed and how much the patient is exposed. Often your fellow healthcare workers, including physicians, don't understand about radiation safety and their personal protective equipment and how that works, especially with the time, distance, and shielding factor. So let's give a simple example. When we irradiate the patient, we receive the scatter radiation from the patient as an operator. The farther we are away, the inverse square law, the less radiation we will receive being scattered from the patient. If we wear lead vests, which we should for protection, and all of our protective equipment, they are designed to absorb the scatter radiation that we get from the patient. The bottom line is that if you're 1 meter away or about 3 feet away from the patient during an exposure, the scatter radiation that will come from the patient and actually reach the lead vest or shielding is about 1/1000th the amount of radiation that went into the patient. So remember, we're not getting direct radiation, hopefully not anyway. We're not getting direct radiation. We just have to be careful about the radiation that we receive and more careful about the radiation that the patient receives. Physicians performing these procedures should be aware of the potential for serious radiation-induced skin injury caused by long periods of fluoroscopy to the patient. We don't see erythema or reddening of the skin immediately. And many times we become so engrossed in the procedure we forget we have our foot on the pedal. All the time that our foot is on the pedal, we are actually exposing the patient. The Food and Drug Administration Center for Devices and Radiological Health has received reports of occasional, but at times severe, radiation skin injuries to patients resulting from prolonged fluoroscopy-guided invasive procedures. Here is a list of some of the procedures that they have longer times and should be aware of the fluoro time specifically. One would be a percutaneous transluminal angioplasty, RF cardiac catheter ablations, vascular embolization, stent and filter placement, thrombolytic and fibrolytic procedures, percutaneous transhepatic cholangiography, endoscopic retrograde cholangiopancreatography, I've always had trouble with that one, transjugular interhepatic portosystemic shunts, percutaneous nephrostomies, biliary drainage, and urinary, including stone removal, fluoroscopy. Here we see a patient with post-procedure burns. Notice that we have a skin dose fluoroscopy graphic above the patient's images. We have patient A and patient B. On patient A, they had 30 minutes of continuous fluoroscopy and the beam was not moved. On patient B, they still had enough fluoroscopy, but by moving the beam to different areas, they've spread the doses to the areas being exposed. The difference is that the direct exposure is very low to different areas as you use multiple areas as compared with one heavy dose exposure, even though we're using the same amount of fluoroscopy. Physicians performing fluoroscopy-guided procedures should be aware of the potential for serious radiation-induced skin injury. Occasionally, this is an unavoidable consequence of the time required to perform a very complex procedure. You can't just stop in the middle of a procedure because you've got X amount of radiation. Some of this, however, can be minimized through a better understanding of how the equipment works and how some operational procedures affect the total skin dose, as we see on the graphic to the left. Physicians performing fluoroscopy procedures should be aware of the potential for serious injury caused by extended fluoroscopy. It is important to note that the onset of these injuries is usually delayed so that the physician can't discern the damage by observing the patient immediately after the treatment. So here we have a graphic or a chart that demonstrates the typical threshold dose and the time it takes to actually get an amount of exposure. For example, if we had early transient erythema or reddening of the skin, we usually do fluoroscopy at about 2 R per minute. If we do high-level fluoroscopy, it's 20 R per minute, such as cine. And in a matter of hours, you can have reddening of the skin. You can also end up with temporary epilation in about 3 weeks. And finally, what you can look at is the fact that you have a period of time where there are different types of damage to the skin that is done by the original exposure. Heart attack and stroke are usually caused by throwing a clot. Here we can see a vessel that has atherosclerotic plaque in the vessel. It's kind of building up on the sidewalls of the vessel like sludge and narrowing the vessel down. As some of the sludge breaks off, it can go into the bloodstream and form clots. So here we have the coronary artery. We get a narrow blood flow, we get plaque formation, and then we get clot formation. Those clots, when they go to the heart, are for heart attacks. If they go into the lungs, you can get pulmonary emboli. And if they go up the carotids into the brain, you can end up with a stroke. This image demonstrates a heart attack wherein a clot has blocked off the blood supply to the tissues of the heart, and we have dying muscle. That's a heart attack caused by a blood clot. Take a moment to study this slide presentation, and here we see the network brain cells that the human body has, which are supplied by blood for energy, blood flow. If you have a stroke, there is a clot that is formed in the carotid arteries and then flow up into the brain and block blood flow into the brain, causing a stroke. When a patient comes into the emergency room with symptoms of a stroke, if we get it in time, we can send the patient to the IR and inject a clot-dissolving medicine to dissolve the clot and reduce the problems caused by the reduced blood flow or the clot blocking the blood supply. This medicine dissolves blood clots and increases blood flow to the arms, legs, or organs in the body. The IR physician can insert catheters, and the doctor would place a catheter into a large vein to either administer chemotherapy to a specific area, be able to provide a route for hemodialysis for patients on dialysis, or be able to provide a feeding tube or nutrition to the patient. These catheters are inserted and they are taken out at a later date. Interventional radiologists also do needle biopsies. This is where a doctor introduces a small needle into almost any part of the body using image-guided techniques to take a tissue sample. We can use ultrasound, CT, MRI, on and on and on. Basically, we use a needle biopsy to get tissue to see if we have cancerous tissue or what type of tissue we have. There are many procedures in interventional radiology that are designed to treat cancer, where the doctor can deliver the cancer medicine directly to the tumor site. There are many types of cancer treatments that are done in interventional radiology, including having the doctor deliver the cancer medicine directly to the tumor site. Let's take a look at a cancer cell and the uncontrolled growth. Cancer can destroy or invade local tissues, or it can metastasize. We're going to start by looking at a video that we've incorporated. For a number of years I was involved with the Advanced Health Education Center in Houston, Texas, in training the inspectors for the Nuclear Regulatory Commission. And one of the areas that we trained about was the use of TheraSpheres or SIR-spheres to treat cancer.
Internal radiation therapy, or SIRT, is a treatment for the type of liver tumors that cannot be removed with surgery. Some doctors may also refer to SIRT by other names, such as radioembolization or Y90 therapy. SIRT is performed by a doctor injecting millions of tiny radiation-emitting beads, called microspheres, into the blood vessels of the liver. These microspheres are about 1/3 the diameter of a strand of human hair, small and light enough to be carried by the liver's bloodstream to reach and become permanently implanted in the tumor's tiny blood vessels. SIR-spheres Y90 resin microspheres are the most common type of SIRT microspheres used for this procedure and have the greatest number of worldwide studies showing their results for fighting cancer in the liver. The SIRT procedure is performed by a doctor using a soft, flexible tube called a catheter. This catheter is inserted through a small incision in the groin and guided through a blood vessel called the femoral artery directly into the liver's blood vessels. The doctor uses a form of X-ray to see that the catheter is going to the correct location within the liver. The SIR-spheres Y90 resin microspheres are then injected through the catheter and are carried within the liver's bloodstream to where they finally lodge in the very small vessels around the tumor. Once the SIR-spheres Y90 resin microspheres lodge in the very small tumor vessels, they give off cancer-killing radiation, but it's a particular type of radiation that only travels a few millimeters in human tissue. This allows the cancer cells to get the radiation while the majority of the surrounding healthy liver tissue is spared. The action of the radiation destroys the cancer cells, causing the tumors to shrink. Most of the therapeutic radiation is delivered within 2 weeks and then decreases to levels similar to natural radiation sources that surround us all on a daily basis.
Interventional oncology is actually a new kind of emerging pillar of cancer therapy alongside medical and radiation and surgical oncology and now immunotherapy to offer faster ways of treating patients with a minimally invasive approach.
One way to treat chest-lung tumors is through tumor ablation. Take a moment to look at this graphic about tumor ablation. You'll notice there's radiofrequency ablation, cryoablation, or microwave ablation.
Patients often know that they have a cancer in their lung when they have coughing, and in particular if they have blood coming with their cough. We call that hemoptysis, and so that's a sign that you may have a cancer in your lung. But some patients present just with pain or with shortness of breath. So those are two other signs that may indicate that you have something wrong in your lungs. So when patients are found to have a cancer in their lungs, there's a lot of different treatments that are available to them. They'll probably first be seeing a medical oncologist, and that's the person who prescribes chemotherapy. The other thing they may hear about is something called radiation oncology. A radiation oncologist is someone who treats cancer using radiation. And then finally there's surgical oncology, and that's a surgeon who would open up the chest and cut the cancer out. But I'm in a field called interventional oncology, and this is a newer field within medicine that arose because of all the side effects and the bad effects that can happen with those other kinds of treatment. So obviously a surgeon opening up your chest, that's a very big surgery, that's a very big procedure to undergo. Medical oncology, sometimes the chemotherapy cancer doesn't respond to it, or sometimes there's too many side effects of the chemotherapy. And then radiation has also a series of side effects that sometimes patients don't tolerate. So what I do is I actually place a needle into the lung. It's a process called ablation, where you put a needle directly into the tumor, and then you either heat it or you freeze it. And there's two different types of ablation: cryoablation, which is the freezing type, and then the heat-based is called microwave or radiofrequency ablation.
One of the more recent types of procedures that's being done in interventional radiology is the use of radiopharmaceuticals that target cancer cells. Researchers are now using image-based dosimetry to personalize the radiopharmaceutical therapy. This approach optimizes tumor irradiation while minimizing side effects. Radiopharmaceuticals offer radiation therapy sparing healthy tissue and potentially revolutionizing cancer care. Radiopharmaceutical therapy is currently revolutionizing oncology, and it consists of the administration of particle-emitting radiopharmaceuticals that is designed to specifically target a cancer lesion while sparing as much as possible healthy tissue. Using this methodology, we are targeting tumor cells. Tumor cells have a shell called a membrane. There are certain proteins such as somatostatin receptor SSTR2 on the tumor cell membrane that can serve as a target for cancer drugs. Here we can see a PET scan where we can see all the tumors lit up. Notice we have liver metastasis, we have a tumor in the kidney itself, and we also have a pancreatic tumor. Once we've found the cancers using the PET scan, we can then utilize a radionuclide to go directly to those cells and target their membranes to destroy the cells.